Thank you. During the presentation, I will discuss the approach and some of the results from estimating the prevalent and potentially undiagnosed HCV infections in Canada in 2011. First, I would like to thank the following individuals for their support and advice in the development of this analysis. The work I'm about to present is a part of a joint project that has been carried out within the Center for Communicable Diseases and Infection Control of the agency by the Surveillance and Epidemiology Division and the Professional Guidelines and Public Health Practice Division. My presentation will describe the methodology and some of the preliminary outcomes of the process. I will provide you with an example of how estimates were produced for injecting drug users and immigrants, and conclude with a few points to stimulate a follow-up discussion. In Canada, information about prevalence of HCV infections is generally limited to studies that are affected by considerable uncertainty, underreporting, and restricted generalizability. In 2009, Dr. Robert Remis released an update to his estimates of HCV prevalence in Canada for the year of 2007. These estimates have been used widely ever since. Last November, Rotterman and others published estimates of anti-HCV seroprevalence from cycles 1 and 2 of the Canadian Health Measures Survey, or CHMS. These estimates, while being the first in Canada to be based on direct measurements of antibodies in a nationally representative sample, were affected by underestimation due to non-inclusion of populations with high burden of HCV. In an effort to update estimates developed by Dr. Remis and adjust for the underestimation of CHMS, the Center for Communicable Diseases and Infection Control utilized two methods that use different data sources. These methods were the workbook method and the back calculation modeling method. My presentation will largely cover the process and results from the workbook method. The workbook method has been used around the world by countries with low-level and concentrated HIV/AIDS epidemic for years to estimate current and project future prevalence of HIV infections and its sequelae. More recently, Chuck and colleagues used it to estimate the true prevalence of HCV infections in the United States. Our approach was to combine population size and anti-HCV prevalence estimates from CHMS with estimates from administrative databases and published or unpublished sources of populations not included in CHMS. The method is based on multiplying estimates of populations at risk by measures of anti-HCV prevalence in these populations, so that the numbers of persons with prevalent anti-HCV positive status could be deduced. Then the estimated numbers of anti-HCV positive persons can be multiplied by measures of HCV status unawareness to estimate the number of undiagnosed persons. In a similar fashion, by applying estimates of spontaneous clearance to the summary measure of anti-HCV positive persons, one can arrive to an estimate of chronic HCV infection. The major caveats of the method are that its estimates will be affected by the quality and availability of the data. Also, because individuals diagnosed during acute stage of HCV infection may clear the infection, estimates of anti-HCV positivity are not the same as the estimates of HCV infection. In addition, awareness measures in one's anti-HCV status may not be the same as awareness of chronic hepatitis C status. The estimation process was built on the assumptions that anti-HCV seroprevalence measures may be related to chronic HCV infection through clearance. The clearance rate of acute HCV infection is the same across all populations. Persons unaware of their positive anti-HCV status have not been previously diagnosed, and that the awareness of anti-HCV positive status is the same as awareness of chronic HCV infection. At the first step, we divided the total population of Canada into a set of special populations, for which data on population size and HCV prevalence were available. For these populations included Canada-born, non-Aboriginal, non-injecting drug user persons aged 14 to 79, two age subgroups not sampled by the Canadian Health Measure Survey, such as children aged 0 to 13 and senior residents aged 80 plus, foreign-born persons, Aboriginal people who do not use injectable drugs, former and current injecting drug users, homeless who do not use injectable drugs, federal and provincial inmates, and residents of healthcare facilities that include nursing care homes and long-term care hospitals. Next couple of slides will give you an idea of how we chose prevalence estimates to be used. This slide summarizes the range of prevalence and awareness measures we obtained for injection drug users. The chosen measures are circled. The table is broken into 3 parts by yellow lines. The upper one represents studies which, in our view, are biased towards underestimation. As you can see, all but one study were carried out in younger drug users with fewer years of injection experience, which may explain the low prevalence. On the bottom, you can see one study whose estimate seems to be too high, given the range estimates about the saturation HCV prevalence available from around the world, and is likely to reflect the population of drug users with many years of injection experience. In the middle, there is a group of estimates which seems about right to be representative of this Canadian population. Of these estimates, we chose measures from the agency's iTrack surveillance system, which, in our view, has better geographical representation and good internal validity. Due to scarcity of Canadian data on HCV prevalence in immigrants, a targeted search on HCV seroprevalence in immigrants in other developed countries has been carried out. Because HCV diagnosis rates in children are generally low, we extracted estimates that relate to adult immigrants only. Also, we attempted to classify studies by the status of immigrants that reflect the concept of HCV risk acquisition. Our view was that refugee, illegal, and HIV-positive immigrants may be more exposed to practices that render higher HIV risk than other immigrants. Well, as you can see from the table, it came out not so straightforward. You can see that both low and high risk groups represented in all 3 parts of the table. Also, the HCV prevalence among high-risk immigrants, which included HIV-positive refugee and illegal immigrants, was higher, 5.2% versus 3.6% in other immigrants. But both estimates were, in our view, too high to be representative of Canadian immigrants overall. In the end, we chose to use the circle estimate from a systematic review by Greenway and others, given that it's between the modeled estimate by Dr. Remis at 0.8% at the lower end and an overall weighted estimate of 3.8% from our own literature review. This slide represents our chosen measures of anti-HCV prevalence for all special populations based on an extensive literature search. For populations with available anti-HCV measures, we picked the estimates that were, in our view, most reliable in a way that I just described. For populations with insufficient or inadequate data on anti-HCV prevalence, such as Aboriginal people, or Canadian residents aged 0 to 13 and 80 plus, we derived mid-estimates and the plausibility ranges by using coefficients or thresholds based on indirect evidence of how anti-HCV prevalence measures in these populations are compared to the measures in populations with reliable estimates. The overall estimate of anti-HCV prevalence, highlighted in orange, was 0.96%, with the plausibility range between 0.61 and 1.33%. The workbook method was also used to estimate the overall proportion of anti-HCV positive persons who were not diagnosed. On the top, you can see the formula we used. In the table below, awareness estimates utilized in the workbook method are presented with their sources. As you can see, the few estimates of awareness available were used for multiple populations. Overall, we estimate about 44% of anti-HCV positive persons were not diagnosed in 2011. We also estimated the proportion of anti-HCV positive persons who have not cleared the virus by adjusting the anti-HCV prevalence estimate for 26% clearance rate from a systematic review by Mikhailov and co-authors. After applying the reduction to the workbook anti-HCV seroprevalence, we came up with the estimate of prevalence of chronic hepatitis C at 0.71%, with a range from 0.45 to 0.99. There are many questions that I would like to ask the audience, such as the ones on this slide. If we have time, I particularly would like some discussion on the last point. How can we get better estimates of population size, anti-HCV prevalence, and percent anti-HCV status aware for special populations? This comes from the observation that some of the data are outdated and some of the measures are based on studies done in other countries. Finally, I would like to present preliminary findings from the workbook method. 44% of anti-HCV positive persons were likely undiagnosed in Canada. Invisible populations such as injection drug users and homeless people, while representing less than 2% of the Canadian population, account for more than 40% of total anti-HCV positive persons. As a comparison, in the United States, the very same invisible populations of injection drug users and homeless accounted for almost 34% of anti-HCV positive persons, as estimated by Chuck and others. I would like to draw your attention to a comparison table where preliminary results from the workbook method are placed together with the Canadian model estimate by Dr. Remis, findings from the Canadian Health Measures Survey by Rotterman and others, the comparable to CHMS American estimates from Enhanced Survey by Armstrong and others, and the results of a workbook estimation by Chuck and colleagues who are adjusted enhanced estimates for undersampling of population with high burden of HCV infection. Thank you for your attention.